So we've talked a lot this morning about data interoperability and APIs and schemas, and what I want to do in this next session is to dive a little bit deeper into how we're thinking about schemas and some of the considerations we've taken in modeling them, just so you get a flavor of the kind of work that goes into building one of these schemas that then is spit out by to catalyze a wrapper, for example, around HL7, or the kind of data that goes into food care. So I'm Ida Sim. I'm on faculty at UCSF. I'm an informatics researcher. I'm also a primary care physician, and I use Epic in my everyday life. Also on our team for schema modeling is Simona Carini, and she'll introduce herself when she does the second part of this presentation. So schemas are important because they're the way that data is expressed, and the way I think about data schema is it's a template that specifies the content of data. And when a software program knows what that template is, then it knows what's to do with that data. It's really as simple as that. It's just a template. So here's the template, first name, last name, and sex. This, you look at it, and it's probably pretty understandable to you. And in essence, that's really all it is. Now, why do we need common schemas? As we've heard, data sources often define their own data schemas, right? You build your product, and then you think about, whether there is a standard you need to think about. So one company might make the schema on the left, and one might make the one on the right. Now, the one on the right says really the same thing as the one on the left, right? There's no right or wrong. No schema here is more right than the other one, right? But one might be more confusing, like male, F is like false for male, or is it female, or, maybe it's a little harder to understand, but you can't say that it's wrong, okay? Now, if you wanted to combine data, you would need to map the representation on the left with the representation on the right, which, this one may not be that difficult, but you have lots of different schemas, and it comes with, representing slightly different aspects of the data. It's going to be a headache, and I'm sure many of you in the audience have struggled with that before. Now, it's especially important that we have common schemas in healthcare, because if you're going to send me data so I can make a clinical decision on my patient, if I'm going to change the dietary recommendations, for example, if I'm going to increase the blood pressure dose, you can't just go mismap that data, okay? You can't lose meaning when you're doing the data aggregation. So if there's blood glucose coming in, I need to know whether it's fasting or random, okay? As a clinician, that's an obvious thing to me. Probably obvious to you too, but some other aspects of clinical descriptors you might not know as much. That just it's missing if it's not there. Is weight self-reported or sent from a scale? Because we know self-reported weights aren't really that accurate, for example. Okay, so common schemas help to reduce ambiguity. It helps to provide important clinical context so that we can make clinical decisions on them, and it increases the overall clinical utility of the digital health data. So we're putting a lot of thought into these common schemas so that these things happen without every developer having to reinvent the wheel and go to medical school and go to data science school to figure out how to do these. Okay, that's the point. So what is our general approach to schemas? As I said, there is no one right way to do a schema, which means we're always making choices. Choices are great, but choices can be very hard. So rather than just sort of barging in there and making these schemas, we have a few design principles or design goals, and these are some of the main ones I just want to go over today, just to give you a sense of how we think about making schemas. So one dictum is not to be too strict and not to be too loose, and I'll get into these in a bit more. The next is ensure that data keeps its meaning and its context wherever it goes, because we know the data is going everywhere. It's coming out of the EHR, it's going to your phone, it's going to some app, it's going to some processing platform, it's going everywhere, okay? And it needs to keep its meaning and its context wherever it goes, and of course support EHR integration. Not too strict, not too loose. Now, when we define a template, we can be very obsessive and compulsive and say, well, you got to say this, you got to say that, you got to say it exactly the same way. Then it would be very clear, be very complete, and nobody would use it, okay? I think that's kind of the lesson learned from a lot of health standards that, HL7v3, a lot of SNOMED, for example. It's very difficult to use because we've erred on the side, I think for trying to be too strict in a sense. The other extreme, of course, is loose templates. In fact, do whatever you want to do, right? That's kind of where we are right now. easy to use because you just spin out your own, but in the end may yield clinically meaningless data either by itself or when we combine them. So our approach is to enable but not require complete descriptions. What do I mean by that? Blood glucose, so this is the instance data from a JSON schema, which you don't need to see. But here, the point is just to say that there is data that is required. If you're going to talk about a blood glucose, you have to have a unit, and it has to be milligrams per deciliter, and it has to, have a numeric value to it. Okay, that's pretty obvious, right? That's required. What's optional is stating whether it is fasting or postprandial, whether it is related to sleep, whether it's on waking, whether it's at bedtime. Okay, so you don't have to say the relationship to a meal or to sleep, but if you wanted to, here's a clean way to do it that is going to be clear. Okay, so in other words, there are some requirements that we do impose on the data. We do enforce the most critical integrity constraints where you really can't get it wrong. The units of measurement, cardinality, doesn't make sense for a blood pressure to have 2 systolic readings and no diastolic readings, right? So certain things we enforce, but there are a lot of other things we do not enforce by choice, okay? So for example, that end dates must come after starting dates, or that a body weight can't be like 3,000 kilos, okay? Now we could put that constraint into the schema, but then it becomes much harder to use and much, there's a lot of baggage there. So we say, you know what, we're just not going to put that in the schema. It's going to be up to you guys as developers, either at the data generating side or at the data consuming side, to enforce those constraints programmatically, okay? And of course, then you can add whatever constraints you might wish. So in striking a balance, toolmakers and data providers can use as much or as little of the data schema that you want, so long as the most important constraints are observed. And by doing so, we will ensure full data interoperability of what we choose to represent. Okay, so it's a balance, it's an ongoing balance. And if we get it wrong, we're counting on the community to tell us, you got it wrong, you got to add something, this has to be required or that doesn't. Okay, so that's the process of working with the community that's here and beyond. Now, as I said, data comes and goes, comes from everywhere and goes everywhere. It needs to maintain its meaning and context. The clinical meaning and context, of course, are embedded, are built into the schema itself. So here, let's say that, I can give you a blood glucose number of 128 milligrams per deciliter, okay? Well, clinically, that doesn't really mean anything to me. I can't act on it because I need to know a lot more. So for example, if the number 120 is actually the average AM fasting blood glucose over a 4-month period, if that number 128 goes far and wide, all this other stuff needs to go with it, okay? So for example, here we have on the bottom descriptive statistic average. So I know it's the average waking relationship to sleep, fasting relationship to meal, blood glucose 128 milligrams per deciliter, over a time frame of February to June 2015, okay? So if I wanted to say all that, I can say it cleanly. This is what we call declarative semantics. And wherever this data point goes, you're gonna have that clinical information. You're gonna be able to interpret it and use it in your algorithms, in your machine learning, in your visualization, okay? The other thing that we need to describe is metadata or descriptions about the data itself. And this information we put in the header of the schema, kind of like in HTML where you have a header and a body, this goes in the header. The header includes the data point creation and ID metadata, the ID of the schema, so this is a blood glucose schema, when that data point was created, and a unique data point ID, which I think you saw on granola. Those are unique IDs, so you can always get at that data point. We also have some information on acquisition provenance, the name of the source or device that the data came from, when the data was collected by the source, and whether the value was reported or directly sensed. There's a whole other class of provenance, privacy provenance, the micro consent thing, we'll go in there, John, and as well as quality of information provenance. So what is the error range around the step count, for example? Also, we want to support EHR integration. Of course, schemas, as has been said before, are annotated to the standard vocabularies used in the EHR world, called for by meaning for use, SNOMED for diagnoses, RX norm for medications, and LOINC for labs. We do spend a tremendous amount of time choosing the right code And if you read our principles document on the website, you'll see what some of the principles we use in choosing the standard term. Blood glucose, for example, actually the Loin code for it is really not quite right. So we actually use the SNOMED code for it. And what we do is it's a persistent URL to an ontology server at Stanford. So, you know, we use open source tools out there to build up this whole infrastructure for representing the meaning of our data. We've touched a little bit on alignment with existing schemas. You know, I think the issue is that representations like FHIR at CCD are, you know, firmly based in the EHR world, you know, in many ways very enterprise-centric. The OpenM health schemas, we come at it from a different perspective. There's a lot of overlap, and we do need to work out where that overlap is, but they're not synonymous. So I think that's an ongoing process for us to work out how these schemas can work together. Now, this is not easy work. Actually, it takes a tremendous amount of time. And so we know that obviously we don't have all the answers, and we have set up the notion of a CLIME working group, which is a clinical measure working group. And the reason for these CLIMEs is, again, no one right schema is right, and we need to make these choices. And sometimes the choices involve balancing sort of technical considerations, clinical considerations, and data science considerations. So we want those people around the table. It's indicated for particularly challenging domains where the trade-offs aren't really clear, and we really need to get, you know, real people who are building tools and say, look, you know, as a data scientist, you want to represent it this way, but is it even usable for you? You know, what are your use cases? How are you working on it now? What do you need? So the CLIME process brings together tool makers and subject matter experts, and we jointly work through domain-specific schemas. Our first CLIME is on medication prescription. We've brought together tool makers and subject matter experts. This happened over the last 3 or 4 months. The tool makers include Iodine, Involve, Wellframe, and PillPack, and our subject matter experts came from Columbia, UCSF, and Duke. So I'm going to turn it over now to Simona, who's going to tell us what we did in the CLIMEs.
So I'm going to continue what Ida introduced, the work that we did in the CLIME for medication prescription. So I'm going to describe a little bit more in detail what the problem space was and our process. So when I was a nurse in the hospital, one of many things that we did was to translate what the physician prescribed into delivering medication to our patients. So we did our order to the pharmacy, and then made the schedules and made sure that the patients took the prescriptions as directed by the doctor. So in a hospital setting, this is a very controlled process. So I put on the slide a little bit the process that we did with the CLIME. We defined what the problem space was, which I'm gonna go over in the next slide. We chose an approach and we proposed a solution. And then we presented to the people in the CLIME. We had a discussion, and we arrived at what we were hoping for, which is a better solution. And then the schemas have been published, and they are on the website, and they're ready to be used in some implementation. So why is this problem important? Because when we move the setting from the hospital, control hospital, to the home, then we have the person in charge of making sure that they follow the prescription. And non-adherence, which is the medications not taken as prescribed, it's actually a costly problem. So between 100 and 300 billion of avoidable US healthcare costs annually just due to this. So it's a problem that a lot of people are trying to address. And so we're trying then to operate in the space between what the doctor prescribes and what the person does. And so we need to model what this in the various pieces of this interaction, starting from the prescription, what is the doctor orders. So most of the players are the same as when I was working in the hospital, minus the nurse. But the setting is the home, and we want to model the different pieces so that we can do some meaningful computation. So our approach, when we decided to model this space, was that trying to make the easy things easy, and I'll have an example of what we call an easy example, and then maintain a clarity of representation for a space that is very complex, and I'll give you a little taste of complication, and make the complex things possible. So we modeled the various components, which is the prescription from the physician, what the pharmacy does with the prescription, and then how the person translates the prescription to a schedule adapted to their own daily life. And then this would allow us to match what was supposed to happen with what happened and do some meaningful computation. So, and after we created the first set of models, we asked our subject matters experts in the CLIME to give us some complex example and to review what we did to see what we could improve in terms of things that we hadn't covered and things that were not clear. And this was the process of the discussion that brought us to make some changes to improve. So here's an example of a prescription. This is a simple case. So the top line is a typical prescription. So the physician says, take prednisone, 20 milligrams, 1 tab daily. So there are a few pieces here. One is the medication itself. There is the name. In this case, it's a generic name, and the strength. That identifies how much the type of prednisone form that it's going to be taken by the person. And it's 1 tab daily. And first of all, there is some implicit information here. That's an oral drug. And then you will see, like, the way we describe the frequency is 1 time every 1 day, which feels a little bit, not exactly how, it's written, but remember that you can say daily in many ways. So another doctor is going to write QD, which means quantum die. This was very interesting for me because we don't use Latin in Italy, so I had to relearn. It was very fortunate. So fortunately, my 7 years of studying Latin in Italy were helpful when I moved to the States. But anyway, so that was very interesting. On the other hand, in Italy, I think they do a handwriting test. If you don't write really badly, then you don't graduate from medical school, I think. Anyway, so, but you can also, for example, someone else can write, 1 and then /D. So there are many ways of expressing something one day. So this is how we structure. And in this way, you can say twice a day would be 2 times every 1 day. So the pharmacy gets this prescription. The physician usually also specifies how many tablets or pills to include. So the physician takes this and delivers to the person 30 tablets of the prednisone. So you notice that the physician didn't say at what time the person is supposed to take the medication. So the person can decide, okay, it's easy for me to remember to take my daily dose when I have breakfast. So if they have a reminder system that says, when I have breakfast around 8 o'clock. So there are already 3 translations. So there is the prescription that gets translated into a dispensing from the pharmacy, and then it gets translated to the schedule for the person. Okay, why does this matter? Because what we call adherence is trying to see how we match what the person did, or what happened, with what was supposed to happen. And the mismatches is where it's the interesting space for this problem. So for medication adherence. And we want to do things in a way to visualize the result, because that's a nice way, for example, for the physician to follow what happens with the person. Because of course, if we're treating something and the condition doesn't improve or something, so you want to look at medication adherence. You want to look how the treatment is taken. So matching the expected schedule with the actual schedule, if we have all the pieces that are modeled properly and we collect the data, so here we can say, okay, the person was supposed to take, according to their own schedule, the drug at 8 o'clock. Well, they ended up taking it at 12. Well, does it matter? In this case, it doesn't. It turns out that it doesn't, because the half-life of this medication is long enough that if one day the person is late, it doesn't matter. But if the person is taking, and a clear example is insulin, well, it does matter. So there is this, so the idea is that you make a comparison, but it's not a given that this person wasn't adherent. It's because in this case with prednisone is okay. So this is just to give you a sense of what's possible when we have all the pieces modeled in a way that they also use the same model and they can work together. So now just to give you an example of how things get a bit more complicated with the same drug. So another prescription says, okay, you take 1 tab every other day and half tab every other day. Now immediately the person, we read it's like, okay, one day I take 1 tab and one day I take half a tab. I mean, we do that translation. But that's not, the computer doesn't know. I mean, in the model, you have to specify that, one comes before the other. So we have an implicit information in the sense that we process natural language by making these inferences, but the model needs to accommodate. And the model needs to be very clear that these things don't happen on the same day. So just to solve this specific example, so we have that in the first, we have introduced the concept of a sequence. So 1 tablet is taken 1 time every 2 days, and half a tablet is taken 1 time every 2 days, and 1 happens on day 1 and 1 happens on day 2. So this is just a sample. There are medications, for example, that are taken with 1 dose Monday, Wednesday, Friday, and then on Tuesday and Thursday, they take a different dose. So the model then is able to accommodate these more complex prescriptions that exist. So that's what I'm trying to explain. So it's easy to make the easy things, but then we have a model that is flexible enough to do the more complicated things. And these are not even complicated. I mean, there's insulin amount that depends on what the blood glucose of the person was just before, or other titration, so a drug that is taken in increasing amount or decreasing amount in different days. So the model can accommodate all this. So within the CLIME, there was a discussion on, again, do we cover everything? Are we collecting all the information that is important for the physician, for the person, for the pharmacist, for the tool makers? And are we comfortable with this representation? So we had a very good discussion with the CLIME. And so we updated the schemas after every discussion until we got the thumbs up. And now the schemas are out into the world. If you go on our website, you can see all the medication schema. It's a set of schemas that cover everything, because then there's also the underlying information like units of measure and various other pieces. So since the CLIME was our first experience doing this kind of process in involving all the different parts. So we asked the people that participated to give us feedback. And so Dr. Lee is a pharmacy doctor at UCSF. The med prescription CLIME got software developer, clinicians, and researchers working together on better modeling of medication data. So he appreciated the fact that we were all from different perspectives working together. And our collaborative efforts have resulted in schemas that will facilitate the design of more effective and efficient solutions, which is, you know, as one of the players, as a pharmacist, is looking at solutions. Dr. Voiles is a medication adherence specialist. She's done a lot of research in trying to understand what factors affect medication adherence. And she said the medication prescription CLIME was refreshing. It's rare that I get to sit across the virtual table from engineers working on tools to improve patients' outcomes. So she was very happy and supportive. The CLIME was an important step in bridging the gaps between technology companies, products, and how clinicians and patients want to see data. More of these need to happen across lots of different measures. Thomas Goetz is from one of the vendors, Iodide, and so that was also very good. This encouraging feedback to explore the same process in other areas. And from Envolve is committed to building its schema and API along the OpenMHealth framework, and that was very good. I mean, good to hear at the end of the process. So this was just an example of one set of our schemas. There's a lot more in our schema library, and this is a snapshot. So on the website, there is, on the left-hand side, there is a schema, and there's also a lot of documentation, including a template on how get you started on building your own. So pretty soon, we're going to actually specifically mark the CLIME-approved schemas. And we're going to talk more about schemas in the afternoon breakup. We have one at 1:30. And what we're going to do is we're going to our plan is to pose these 3 questions to our audience and work together to get some proposed answers. Thank you.